going to find there all of our sessions, so you can share with your team, or you can watch them again, or you can watch the ones that you are not able to attend live. And we want really to interact with all of you during this meeting. So please use the chat box as in the way that you want to, and please type your questions on the Q&A box. We are going to have a break on the middle of the session and one in the end. So we are going to discuss all of your questions during the meeting, or our panelists, our faculty is going to answer your questions as much as we can. So please interact and participate with us. This is very, very important. So tomorrow we are going to have Dr. Anderson talking about what is isomerism, and this is going to be a very nice morphological session. Please join us tomorrow. And on Monday, Dr. Mary Cohen is going to show the echocardiography features of isomerisms and heterotaxy. This is going to be very nice. Well, we are going to have next week one session that has been arranged, has been organized by our Italian delegate, Dr. Elio Caruso. And this is going to be in Italian. So if any of you are able to speak Italian, please join us. But what I want to tell you is that even if you're not originally an English speaker from an English speaker country, but you want to do some sessions with Congenital Heart Academy, please talk to us. We can arrange meetings with our international speakers and for all the societies and the organizations that you may want. So please talk to us, send us an email, and we can arrange and organize a very nice meeting for your region. And now we are going to start this meeting. This is going to be a very nice one. We are going to have this combined with the Caspian, and Dr. Bezad is going to talk a little bit about Caspian for us. And now, Sasha, if you want to introduce him.
Yes, thank you, Grace. Thank you, and welcome to all the people. Whatever part of the day here is morning, afternoon, or evening, we are very happy. And we would like to thank really Bezad Alizadeh for his relation with us was very direct and some good connection and collaboration start very easy, and we are very happy today because the idea is not coming from Congenital Heart Academy, but we marry this fantastic idea to have this special meeting dedicated to what is unconventional. As we know, probably most of the things that we do in congenital heart patients are off-label, mostly. Also medical therapy sometimes is like this. So it's my big pleasure to invite Dr. Bezad Alizadeh to introduce himself and to introduce Caspian meeting. Thank you very much.
Thank you very much, Sasha, and thank you, Grace, and all the team. It's a very good and very good pleasure for me and all the team to be here with you. I do appreciate to have this opportunity from the Congenital Heart Academy to have a good relationship and good collaboration with Congenital Heart Academy and all the world. And I thank you all for this opportunity. Thank you for introducing me. I am Bezad Alizadeh. I'm pediatric interventional cardiologist working in Iran with my good delegates all over the world and my good faculties from the different countries in the region. We started to have such meetings from 2014, but officially we started in 2017. Now Caspian is a broad name and working especially on congenital heart disease and mostly on interventions on structural, valvular, and congenital heart disease, and also the fetal cardiology. So there are some good friends all over the world from working as have a good collaboration with us in different countries. Some of them are here and now joining to Congenital Heart Academy, and I think that it would be a very good time to expand our experiences and also to exchange our experiences. Anyway, I want to introduce here some of these guys. Hamid Amuzigar is one of my best friends. He is professor of interventional cardiology working in Shiraz. And one of my best friends and very good old friend, Workam Prampan. He is from Thailand and is working as a very good interventionist, and I have learned many, many things. And Dr. Teen from Vietnam, he's the chief of the Congenital Heart Society in Saigon and Ho Chi Minh, and I'm so proud to have such a friend. And Supa is another friend. He is working as in interventional pediatric cardiology, as in also in Thailand. Hojat is also with us. Hojat is a very a good friend of mine. He is a very, very, very well-known interventionist in Iran, and he works in congenital and structural heart disease. And also, Kehan is here. Kehan is a very old friend of mine, from when we were in primary school, as I remember. And he's a very good interventionist also. He works in Tehran, the capital of Iran. Anyway, I'm so proud to be here, and I hope to have a good meeting today. And I thank you all who are attendees in this conference. Thank you.
This is amazing. So if you want to start, the first presentation that we're going to have is from Dr. Vezad.
Okay, thank you. So, well, do you have my screen?
Yes, we can see it.
Okay, just a few minutes,
Need
please.
to go back. Yeah.
Yeah. Well, today, the session is about the unconventional interventions for congenital heart disease. And I'm going to speak about unconventional VSD closure and about the device selection in this one. You may all know that because of some limitations and sometimes because there's no perfect device for every intervention that we want to do, sometimes we use another devices from the another purposes. VSD is one of those special characters that we started with unconventional VSD closure first, honestly, because of some limitations in my country. And but after a few years, it became a very famous topic and all over the world. And so most of the my colleagues here in Iran also, and in the region, I know that right now, use many devices for unconventional VSD closure. Well, I have no disclosure, but I have to thank my best friends in Mashhad University, my colleagues, Dr. Birjandi and Dr. Naqibi, that they're always with me and in my cath lab, and they're very good friends and very good interventionists here. Device technology and also echo technology or imaging technology helped us to be more familiar with the defects and understand more about the configurations of the devices also. So there are many devices used to treat congenital cardiac defects as an unconventional or off-label basis. If we want to focus on VSDs, first of all, we have to know about the types of the VSDs. You know that VSDs are distributed through the septum of interventricular septum. There may be on premembranous side, there may be supra crystal, or maybe mascular, maybe inlet, maybe outlet, and there are vast majority of kinds of the VSDs, and no two VSDs are so similar to each other. But we can classify these VSDs based on the location of these VSDs. You know that most important of the VSDs are premembranous VSD, because more than 80% of the VSDs are located in this area. So when you are going to go for an intervention, you have to answer to many questions about the site of the VSD, about the morphology of the VSD, and about the many structures around. So you have to start with these questions every time. But the most frequently asked questions are, do we need to close the VSD at all? Sometimes it's a very great consideration. Sometimes you have to wait, and sometimes you have to go forward. And when is the best time for closing? Is a baby, for example, 5 kilogram, is a suitable baby for going to VSD closure or not? And also, what is the best device to choose? Is all the devices that are many brands of these devices are all suitable for your defect? Maybe not. Anyway, how to choose a device? What is the best way? If you want to choose a device, we should know the site and morphology of the VSD. This is a very, very important question that you have to answer every time. And the second is to know the quality and the shape of different devices. If you want to be a good interventionist, before everything, you have to know the morphology and the site and the shape and the location of the VSD. And the second is to know the quality of the devices that you want to do. So what are the most important considerations regarding the size of the VSD? It is very, very concerned about the hazards and adjacent structures. For example, aorta, it's very important to know about the leaflets, the prolaptic leaflets, and sometimes about the tricuspid. You know, most of the VSDs are located between these two structures. The most important one, premembranous VSD, are located between these two structures. So whenever you are going to close a VSD in this area, you have to know about the aorta, and also you have to know about the tricuspid. So what is the shape and what is the morphology? You know, as I told you before, most of the VSD is located between the septal leaflets and the anterior leaflets of the tricuspid, and it's very, very close to the aorta. So this kind of membranous or premembranous VSDs are the most common form of the VSDs. And sometimes the VSD have very special and particular shapes. For example, aneurysmal VSD. Aneurysmal VSDs, most of you are so familiar to these kind of VSDs. An echo, you can see a pouch that is sometimes is moving, and sometimes you have one orifice or two orifices or many orifices that are very important to know about them. So the aneurysmal VSDs are sometimes between the aorta, and sometimes some part of the tricuspid leaflet is involved with this pouch of the VSD. So, and what are the important considerations regarding the device itself? So you may know that a nitinol braiding gives a device more flexibility and more adaptability for going to a very special defect. So you have to know about the distal clamps, that distal clamp reduces the risk of trauma and formation, and sometimes a low aortic side profile is an advantage for a device when it's going to the LV side. There are some known form of the devices that are most of you are familiar from the AGA, from the LifeTech, and there's are many shapes. For example, the muscular VSD occludus and membranous VSD occludus. These are some familiar standard forms, and also there are some kind of coils. You may know about the Lee coil. Dr. Lee is one of the best friends of me. That's the PFM Lee coil is another form of the VSD occludus right now. And also the membranous occluder may be some different shapes, for example, asymmetric or eccentric form of the occludus. Everybody have to know that. But about the off-label devices, many times we can use another devices instead of these standard forms. For example, AD01 from the unplasted occluder type 1 or AD02, or sometimes the additional size of the AD02 or some kind of the occludus that we sometimes use. And also about the occluder duct occludus. Occluder duct occluder have two standard forms, a standard PDA and something and another one with long shank. And these are two types of the occlusive duct occluder. And just proceeding to the cases, I want to show you some cases about these. First of all, I want to speak about the classic VSD device closure using muscular ampulla. That's an example from 10-year-old boy, 25 kilogram, and on X-ray, we have increased CT ratio with mildly increased on vascular marking, and no problem on EKG, normal axis, just mild on LVH, and PAP pressure was normal, and room SpO2 was about 97%. Well, as you can see here, it's upper muscular VSD off the membranous side. It's not so big, and for doing this, we have to make an AV loop. You're all familiar with this kind of AV loop making. And after that, in this time, we're using a muscular type VSD occluder from the ampulla. And by going inside and through the VSD, the most familiar technique is going to the aorta and coming back to the side and placing inside and deploying the device very nicely. This kind of VSD is not so problematic and not so challenging. But most of the time you can use the familiar kind of standard devices. And this is the final result. On case 2, I want to introduce to you another baby, another boy with subaortic premembranous VSD that had been occluded with AD01. It's a kind of unplastic type 1, 75 kilogram, and 70.5-year-old boy with 74 kilogram. And again, with normal chest X-ray and normal EKG, and PA pressure was normal also, SpO2 was normal, and I used another 4x6 unplasted duct occluder. As you can see here, the VSD is not so big, but there is the very mild prolaptic right coronary clasp. This time, for making the AV low, I am now coming to the SVC and making the AV low again in the aorta and again in the place. You know, we have a very unproblematic prolaptic right coronary clasp, and finally into place with no problem in the aorta. And this is the final result, as you can see here, from the lateral position, nicely in the position. This time we use another kind of VSD duct occluder, a duct and plus a duct occluder. And another case for aneurysmal premembranous VSD, which was occluded by Occlutech duct occluder. It was a 10-year-old gal with 36 kilogram, and again, chest X-ray was normal, normal EKG, and the pressure of the pulmonary was also normal. You can see here that in this time, the case is an aneurysmal form with a pouch, again going into the pulmonary artery to make the AV lobe and snare it back to the femoral vein, making the AV lobe, and then again in the aorta for deploying the first disc, and going into the place. Fortunately, in this type of aneurysmal, there was only one orifice, but this is not, we are not so lucky all the time, because there may be another holes and another pouch in the pouch. So in this time, we had only one orifice. So I can use very nicely from one Occlutech duct occluder. And you can see here the device is in the place, but when you are using these kind of occluders, every time you have to have some projections and some injections from lateral position, because you may be wrongly in the pouch instead of to be in the RV. So you have to use the lateral position to see the device very nicely in the lateral position and to be in the RV. So another case where Occlutech duct occluder was a 10-year-old gal with 23 kilogram, but right bundle branch block. But this is a residual VSD. The residual VSD sometimes is a very challenging cases because the shape of the VSD is not so perfect. So in this kind of VSDs, you have to have very, very good images from the echo and something like that. In this case, she was tetralogy followed, and after tetralogy followed operation, we had a residual VSD. So we tried to close the VSD by using Occlutech duct occluder size 8 by 10. As you can see here, the RA is somewhat enlarged, and the pouch of the VSD, and this is the surgical patch, and you have to cross this patch, so have to be very, very careful sometimes because it's not the normal tissue, and you have to take it very, very easily. Because the patient was a kind of tetralogy followed, and after the transannular patch, you have the free, as you can see here, free pulmonary regurgitation. And after that also, we have no problem with the aorta, as you can see. Again, snaring in the pulmonary valve, in the pulmonary artery, and coming back into place. Should be very careful in this time because this is a patch, it's not a normal tissue. As you can see here, crossing the patch, and you can see a very narrow neck of the device. It is because of the patch, because of the surgical patch, and you have to be very careful about the tricuspid also in these kind of VSDs. And after some injections, fortunately, is into place with no problem, an aortic valve or tricuspid. And another case with a very small aneurysmal VSD occluded by audio 2, sorry, occlutech doc occluder. Again, the patient, I'm sorry because I'm going so fast because of the time, taking the time. This is another aneurysmal VSD. You can see it, the shape of the aneurysmal VSD is some kind different, and you have to cross the main orifice because sometimes there are two adjacent orifices and you have to cross the main orifice to close all of them spontaneously with one device. Crossing the sheet, it is completely closed. So the device that we have chose may be something around the diameter of the sheet, the long sheet. And here, once again, under place with no residual. Fortunately, closing all the orifices, but no problem on the aorta. And so every time for giving a good idea, you have to think and you have to choose the right device and also the right form of the morphology. So the main question every time is about the morphology and the type of the device. So with these considerations, I'm sure that everybody have good idea to close the VSDs, such kind of VSDs. Thank you very much, and thank you for your attention.
Thank you very much, Behzad. It was fantastic, and as you say, probably the planning to do something or not to do something is probably the most important decision making for such a difficult and complex case. And now we go directly to our colleague from Bangkok, in Thailand.
Thank you, Sasha.
Is Dr. Borakan Romfan. Sorry if I make some mistake. And he will talk about unconventional BSD closure, the retrograde approach, when and why use this. So, Borakan, welcome, and please can you share your screen and open your microphone?
Yeah, thanks, Sasha. Can you hear me clearly?
Perfect. Thank you very much.
Okay, all right. And so first of all, thanks Behzad and Caspian and also Congenital Heart Academy allowing me to be in this wonderful webinar session. So please, if any one of you would like to interrupt me anytime, I would be very appreciated. So my talk is actually will relate to Behzad previously mentioned about the VSD closure, but I would just focus mainly on the retrograde approach, when and why. What I want to share is, this is my disclosure. So what I want to share is when you have the angiogram, you can see that there are varieties of the VSD. Some is like a window, some is like a sac, and also sometimes it's like a tube. And again, depends on where is your VSD. I would not focus only for the perimembranous. I'll focus in general kind of VSD. And again, just to appreciate that this hole is like a window. But this one, there are multiple exits, and this one is like a tube. And also sometimes when you deal with muscular VSD, it's very funny looking shape, like this one. It's like very elongated one, and also having one exit here and also another exit there. And this is also a very difficult VSD to deal with, because you have a big one here. This is actually top TOF patient, and you have a muscular one here, which is very close to the tricuspid valve. Again, it's not easy to consider whether how you're going to deal with this kind of muscular VSD when it's close to the tricuspid valve. Of course, this one you need to discuss with the surgeon, because this is not your job. Or this one, after the surgeon did surgery, and for some reason Behzad showing you that we may have an issue of the residual VSD after the surgery. So these are the things that we need to think about when you try to deal with the VSD. So again, retrograde approach. So in my assumption, I will go for two kind of things that I'll have to discuss with myself. First one is about how to cross it retrogradely or antigradely, and second one is about to deploy the device. So I'll mainly focus on the retrograde crossing and retrograde deploying. So what does it mean, retrograde crossing? So here is the cartoon showing that when, in general, when you go to the VSD, you normally go from the aorta, and then you cross the VSD by putting the wire into the defect, and then you know, just let the wire flow somewhere. Most of the time, you can leave the wire into the pulmonary artery, and many times, and in many operator, they will try to push the wire just up against the flow and then leave it around the SVC, and that is a kind of very common approach. And as you can appreciate here, that with this kind of approach, you can just cross the defect by only just putting the wire and let it flows into the defect, and you can really happy to see the wire is just you know, crossing the defect. And this is the way that in some centers around the world, they would try to cross a VSD without fluoroscopy. At least, you know, a good friend of mine in Indonesia, they try to do that very nicely, showing that this is very feasible, and this is a very good idea to do when you don't want to expose to the radiation anymore. And after you cross it, and then you think about what to do next. But when you're going to use the retrograde crossing, I would say that most of VSD, you can use this kind of techniques. Why? Because again, as I said, it's follow the flow. It's easy for you to just you know, let the wire just pop in through the defect and then just let it in. And this is another thing that I've learned so many times, because sometimes when you try to cross it from here, I mean from the left ventricular side, and for some reason your conduction system is very proximal or very close to the defect, and you know it beforehand, because when you try to cross it, and then you just feel that there is some bundle branch block coming out, or even heart block completely occasionally happen. So with that, at least that warning you that you need to be very careful and cautious whether or not you should proceed for this procedure. And sometimes when you deal with the defect, which is so pointing upward, like 11 o'clock, this is a thing I've learned from Chen. Thanks for him to allow me to put this kind of nice picture that he tailor-made his pigtail to be in angulation in regards to the angle that you want to cross the defect. And this is quite useful when you deal with the very upward pointing of the defect. Most of the time it will be the subpulmonary VSDs. And here, just to compare with you, this is a peri-membranous VSD. Most of the time it will go like this. And for the subpulmonary VSD, it will go like that most of the time as well. So with this, you cannot just let it flows, but with this, you need to at least anchoring your wire and point it up to the pulmonary artery. So this is quite very useful technique using the cut pigtail. Some doctor, they may also use the IMA catheter just to allow the guide wire to go upward. And I would like to also discuss about retrograde deploying. So what does it mean, retrograde deploying? Retrograde deploying means that when you already have the wire, you don't need to do like every loop, but you just you know, advancing the guiding catheter or sheath, long sheath or delivery system onto the right ventricle, and after that you just you know, ready for yourself to implant the device, just like I'm showing you here. So again, when you have the sheath ready into the right ventricle, you just open the device like that, and then just slowly manipulating your device, you will be able to you know, sandwich the defect by your device, just like what you see here. Sorry if you not very see it very clearly, because it's not the Sydney, but this is fluoroscopy recorded. And again, with this, our colleagues, I have very limited experience using non-fluoroscopy closer to defect. But again, just to show you that this is feasible to use the echo-guided non-fluoroscopy device closure for the VSD. And when you ask me when we will use this kind of techniques, I would say that first of all, you have to have the double disc device. Whatever you have, you need to have it. Something like, again, the ADO2, you see double disc device, the AVP2, sometimes you can use this device in this kind of fashion. In Thailand, we also have the Cocoon VSD device made from the Eclipse Medical, previously was Vascular Innovation. And the Amplacer, definitely, you can use this muscular VSD. MFO from China, LifeTech company, they also have the symmetrical VSD device. And also from the Pool company, they also have membranous VSD device. Again, just to confirm that if you want to use these techniques, you need to have double disc device. Why? Because it's easy to deploy with this device kind of design. And secondly, it will be quite stable and you'll be like very happy to make sure that you can go back home and sleep well over the night without waking up in the middle of the night just to say, oh, device embolized. And the second thing that you need to have is when you try to think about using this deploying techniques, it means that when you deal with the VSD that close to the tricuspid valve. Again, this is a four-chamber view showing the aneurysmal VSD. And again, this is very close to the tricuspid valve septal leaflet. And also there's, you can say this is a tricuspid valve regurgitation or LV to RA shunt whatsoever, whatever you can say. But when you go with the short axis view, again, very clear, this is aneurysmal type defect. And part of the defect is the tricuspid valve tissue. And there's a shunt just coming up here and then going down towards the tricuspid valve and heading towards the right atrium. And for a long axis view, you can appreciate that when you see the defect, you can't see the aortic valve very well. So it means that there's a little distance between the aorta and the tricuspid valve and the VSD. What does it mean? It means that at least your defect is not completely heading towards the aorta, but it's actually heading a little bit away from the aorta and heading towards the tricuspid valve. So with that kind of morphology and with this kind of scenario, you need to think about using these kind of techniques. And again, just to show you, it's quite simple. When you try to deal with this, again, you can use fluoroscopy to guide your procedure very nicely. You see the disc very well. You see how long or the distance between the disc and the defect like that. And the key of, the advantages of this kind of deployment in this particular morphology is you can squeeze and sandwich the aneurysm. And again, immediately after you squeeze and sandwiching it, you can appreciate it how the device will, involve or change the severity of the tricuspid valve regurgitation and also the residual shunt. And again, this is the patient previously just show you the echo, and immediate after you open the disc and sandwiching it, the TR or LV to RA shunt is completely abolished. And again, with the cable attached, you can appreciate that the disc on the left side is actually below the aortic valve with very minimal disturbance of the aortic valve. And again, just to confirm that there's no residual, there is no a particular or very obvious residual shunt after before you release the cable. So again, this is very, very good idea to use this kind of technique when you deal with the TR and you deal with the aneurysmal type defect, and then you want to know exactly that how the TR will behave after you put the device in. And this is again just to confirm the previous patient. Immediate after we release the device, this is before, and this is immediate after. You know, there's a question in the chat box previously asking about the small VSD closure. I would say that in my country at least, even if we have the small VSD, but if we have the LV to RA shunt like this, we need to think, because that is more chance of the patient to develop the endocarditis. So again, if I have the patient like this, I will try to close the defect just to abolish the LV to RA shunt. And again, I have to aim to be completely occlusion of the flow and also abolish as much as possible the LV to RA shunt. So then we will discuss a little bit on the window tubular type PMVSD. Should we do this? I will show you the example of the patient. Again, this is the patient, you know, showing this kind of tubular kind of jet of the VSD, and there's a little bit, just a little gap. As you can see here, there's a gap between the aortic valve and the defect. So it's kind of perfect kind of defect that you can use the retrograde approach, and you can make sure that the disc is at least a bit away from the aortic valve, so it's less likely to have a problem. But just to show you, in general, we're gonna do this. We open the disc like that, and then we just pull the disc, you know, slowly until we touch the septum, and then you just try to advance the body and the disc on the other side, just to squeeze the defect. This is ADO2, probably, I can't remember what size, but probably about 5 by 4. But the problem, not the problem, but the issue when you try to deal with this kind of technique is sometimes, you know, it's not really what you really want to see. Tin, are you around, or Bizat? If you can tell me, are you happy with this position?
Warakan.
Yep.
We may not really happy because the weight of the device in the RV already. If you release, maybe it's embolized.
Yeah, thank you. So that's the thing that's very important. When you deal with this kind of approach, you need to be very careful that at least the disc, which is body here, should be on the left ventricular side, or at least in the middle, not just like this. If you can appreciate this very, very slowly, you can see that this here is already into the right ventricle. And again, Tin mentioned very nicely that with this, you run the risk of embolization. So make sure that at least you put the device into the right position. So that's the reason why we eventually need to reposition it. So by doing like pulling a little bit further, you know, close to the septum, and try not to push so hard, and then you try to keep the body here in between the septum rather than just keep it into the right ventricle. And then this is the final result. Again, it sits very nicely. The body is in between the septum, and then you're happy. You can go back home very, very, very happy without any problem. You know, some doctor, they may prefer not to do this because the disc on the side of the left ventricle, there will be the hub here, and you know, some doctor, they may feel like it doesn't look very nice to have like protruding kind of hub into the left ventricle. But to be honest with you, at least we did that for many years. We don't have any problem with that kind of hub of the ADO2 on the left ventricular side. I'm not sure if Tin or anybody can share later on whether any problem with that kind of hub here is in the left ventricle or not. How about the outlet VSD? So that's quite challenging to use these kind of techniques. I'll show you why. So we have the VSD, which is typical for the outlet VSD. Again, the protruding the defect, protruding of the aortic cusp, and then the defect is like that. And you can appreciate that the hole is actually not that big. It's actually quite small, but its degree of the protrusion of the aortic valve is quite, you know, significant. So with this, some center, they will not touch it. But so we did this case with Dr. Kim Mong-U in Yangon. So unfortunately, with in his hands, you know, the surgeon is so busy with other complex kind of not complex but very urgent surgical procedure. So they don't have time to deal with this kind of thing. So we know exactly if we just leave the patient like this for at least 1 or 2 years, the valve gonna prolapse very badly, and they may cause even worse on the aortic regurgitation or LV2RA shunt. So at that time, we decided to close it. So again, just to show you that when we try to use this retrograde kind of approach, it looks okay. You know, the disc on the left side is below the aortic valve, it should be fine. But eventually, without prediction, after you release the cable, the disc of the left ventricular side is just hugging, not in between the aortic valve, but getting inside the defect. And again, that caused the residual shunt. And again, it's not stable. So with that, eventually we decided to remove this out because it doesn't look very nice. And of course, there's a residual shunt here, and its risk of the embolization is quite high. So we eventually need to remove that out with the snare. I will skip this for the interest of time. But just to show you, then eventually we managed to close this defect by the antegrade approach using another device, which is MF4 instead of ADO2, in order to deal with this kind of defect. So again, for me, if you want to use these techniques, I would not try to use it for the doubly committed subaortic VSD. Why? Because it's difficult to predict the outcome. So in conclusion, ladies and gentlemen, I would like to conclude that I will use the retrograde approach. Why? When I have the double disc device, and of course I'm very concerned on the tricuspid valve function, and I want to make sure that when I deploy the device sits nicely with very less problem with the aortic tricuspid valve. And this is quite handy in terms of the time of the procedure, because doesn't need a loop creation. So it means that it's easy comes, easy go. Aortic valve function, unfortunately, with this kind of techniques, it's not very easy to evaluate. So be careful on that. And sometimes you need to use the puncture arterial approach in order to get a proper LV angiogram. And it's more risk when you deal with small babies or small child. So thank you very much indeed, and hope my talk is useful for all of you guys. Hello, are you with me?
Yes, amazing talk. Thank you very much. I think very good talk, both of you. So we were able to have a good overview of the VSD closure. Thank you for that. So I think now Behzad is going to introduce our next speaker.
I'm ready for next.
Okay,
hello?
So hi, Behzad.
Okay. Hojat, are you ready? Okay, Hojat Mortazayan is one of our best friends at as I told you before, he's a very famous and very well-known congenital interventionist in Tehran, capital of Iran. And I myself have learned many of from him. So I know that today, unfortunately, he's not so well because of the COVID-19, I think. And I hope everything is okay, Hojat, to you today.
Okay. Can you see me and can you hear me?
Yes, we can hear you very well. You just need to click on the presentation mode on your PowerPoint.
Okay. I want to present the unconventional PDA closure in a very small baby with complete thrombus in the venous access. This patient is very small infant. Age of this patient was 18 months age, and this procedure was done near 3 years ago in our hospital, Rajai Heart Center in the Tehran, capital city in Iran. I want to show our problem in these patients. In the beginning, we try to giving venous access in these patients, but unfortunately, all of the venous access from their right and left foot was completely occluded. This patient had near 6 months ICU stay for surgery because he has a history of the diaphragmatic hernia repair and hypoplasia in the left lung. Another venous access from the left femoral vein showed complete thrombose of the venous access in the left side. You see just multiple collateral connected from the different type of the venous connection to azygos, and finally azygos connected to the SVC and drainage to the RA. We go for arterial access, and after giving the arterial access, we inject first injection in the LV for evaluation of the LV size and evaluation of the some defect in the LV. You see the LV is enlargement. Trabeculation of the LV is very prominent. You don't have any VSD, but you see very big and large PDA with significant left to right shock. Another injection in the descending aorta showed a very large and big PDA with significant left to right shock. Before the closure of the PDA, we enter in the main PA and we evaluate the RV and main PA pressure before the selection of the device. RV pressure in these patients was 55 millimeter mercury, and mean PA pressure in this patient was 38 millimeter mercury. Patient was the PH, and for a selection of the first device, we decide to select MFO occluder with size of the 5x4. We inject another injection in the RAO view for better evaluation of the size and shape and diameter of the PDA. You see a diameter of the PDA is big, shunt is very high, the diameter of defect is near 3.5 millimeter. We used a MFO occluder. This is the MFO size of the 5x4, and we used a 5 French long sheet for implantation of the device from the retrograde approach in the aortic side. But unfortunately, after the putting the MFO, you see a significant protrusion of the aortic disc in the aortic side. After the deployment of the two discs in the pulmonary side and aortic side, we evaluate this patient with transthoracic echocardiography, and transthoracic echocardiography showed a significant protrusion of the disc, especially in the aortic part. For better evaluation of the disc and better showing the position of the aortic disc, we inject from the long sheet, and you see protrusion of the device in the aortic side is very high, higher than 50% of the device is inside of the lumen of the aorta. And another injection from the lateral side showed the same view. Exactly, we will not able to release this device, and we decide to capture this device and select another device for occlusion of the PDA. We captured this device from the cable inside of the sheet very easily. Another injection before the selection of the second device showed a very big and large defect. And for closure of this defect, another selection of the device for us was the selection of the Cook coil. Size of this coil is 5 by 5. And we implant the coil and 2 loops inside of the pulmonary and 3 loops of the coil inside of the aortic side. After the first injection, you see a mildly protrusion of the coil inside of the aorta and significant residual shunt. We decide to capture the coil and change the configuration of the coil, especially in the aortic side. After the recapturing of the coil and the redeployment of the coil inside of the aorta, you see the better position of the coil, and injection before the release showed a significant residual shunt. But by transthoracic echocardiography and after near 10 minutes waiting for evaluation of the residual shunt, we have a significant residual shunt, linear residual shunt to the main PA, and we decide to input second Cook coil in upper part of the first coil. Before the release of the first coil, we put a hydrophilic wire. Hydrophilic wire enter from the upper side of the Cook coil, and we put a 4 French catheter for deployment of the second coil. And for selection of the second coil, we used a 5 by 4 millimeter Cook coil. Second coil is the 5 by 4, and first coil is the 5 by 5 millimeter. After the deployment of the second coil, evaluation of the position of the coil and the residual shunt by the transthoracic echocardiography showed very good results. And we decide to release the first coil. Position of the coil in the aortic side is good, and we don't have any significant protrusion, and we don't have any significant residual shunt by the transthoracic echocardiography. And we released first coil. For the release of the first coil, it's better to release a small coil at the first and release this biggest coil in the second stage. You see a release of the small coil, and after the release of the first coil, injection showed a tiny and mild residual shunt, but by transthoracic echocardiography, linear shunt was not very significant, and we decide to release the second coil. You see the technique of the release of the second coil. Sometimes while the release of the coil, you have some complication while the release, because while the rotation of the coil, you cannot detach the coil from the cable. This problem was happened for this patient, and for release of the coil, we try to put the coil inside of the delivery sheet, and we release that. And after release of the second coil, injection in the aortic side showed a good position of the coil. Protrusion of the coil inside of the aorta is not very significant. Residual shunt is not very significant. And final position of the coil showed in the AP view in the good position. Evaluation of the kidney in the final procedure for some of our patients was done in our center. This case is very challenging for us because history of the long stay in the ICU and complete total occlusion of the venous access from the lower extremity is the very big question for me and for my colleagues. My question in the follow-up, in the next follow-up of this patient is, what will happen for this patient with complete total occlusion of the all of the venous access in the IVC and in the abdominal part? And if you have any comment for follow-up of this patient in the future, I will be very happy to see your comment for follow-up of these patients. Thank you so much.
Very nice case, a very nice case. And this, for sure, this is something that is very difficult to all of us. And we are going to have one talk with Dr. Franking, and he's going to talk about recanalization of occluded venous, systemic venous system. So maybe he can talk a little bit about the outcome of this venous occlusion. This is going to be a good discussion. I have one question for you. We can wait for the discussion, but I'm really curious about the femoral artery of this patient. If you had any complication because you used a big, amazing.
No, we don't have two part of the bilateral femoral artery was patent, but complete occlusion just in the venous access.
Perfect. This is very nice. So now we are going to move on to our next speaker. And I just want to tell you again, please type your questions on the Q&A box. We're very happy to answer all of them. And then we can choose some of them to make live during the discussion that is going to be soon. So now we are going to talk about unconventional imaging for ASD closure with Dr. Kian. He is a professor of pediatric cardiology and Children's Medical Center in Tehran University of Medical Sciences in Tehran, Iran. Thanks for being with us, and we are going to listen very carefully of your presentation. You are muted.
Hi, everybody. First
Hi.
of all, I thank the Congenital Heart Academy and Caspian Foundation for inviting me to this session. I now share my slide. Yeah, it's okay?
Yes, perfect.
I have nothing to disclose. Echocardiac assessment for ASD device closure, we can divide it in two parts. One is before procedure to see the feasibility of ASD closure, the rims, the number of defects, the size, and etc. And one is during the procedure. So the options are esophageal echocardiography, intracardiac echocardiography, 3D echocardiography, or some mixtures of these options. All of them provide sharp and reliable images, and complication rate for all is low. However, they are expensive for buying, especially in developing countries, and expensive for maintenance. What to do in developing countries when they cannot afford these modalities? One option may be transthoracic echocardiography. It's much cheaper and available in all centers. It can give us a good image quality, especially in children. But the quality of image is poor, especially in older patient, obese patient. It's slow in relation to transesophageal echocardiography, slow to switch between fluoroscopy and echocardiography, because we should move the drape and put the probe on the patient and so on. It's relatively slow, and there is a risk of infection. It needs much caution during the echocardiography. Stop flow technique for balloon sizing, it's possible, but somehow difficult with echo. What is in the literature? There are papers and reports about the use of transthoracic echocardiography for AST closure. I summarize them here. There are reports from Belgium, small kind of patient. From my country, there are at least 4 reports. Reports from India, China. The report from China is about the adult patient. There are reports from Germany, UK. The largest one is from UK. One from US. It's a case control study. Not too many patients, but a case control study. And also from Iraq. Totally, there are 730 cases, and in 96% it was successful totally in all of these reports. What is the experience in my center? We had around 200 to 300 AST closures, I think, since the beginning of AST closure in our center till 2018, where we bought transesophageal echocardiography, and now we do it under transesophageal echocardiography. During this time, we had one device embolization. It was an ASDR device, which we use not too often. And one suspected erosion we had, and it was a bloody effusion, which is relieved by one time by and not occurred again. So it seems that we had a good result with the transthoracic echocardiography. But what about the echocardiography assessment before closure? So the same problem exists. Transesophageal echocardiography may be the best, but it's not available everywhere. The size is important in developing countries. They have limitation in our shelf, and we have not all device size available in our shelf in many centers. What I do is a measurement of the device in subcostal view at 4 angles, 12 o'clock, 1.5, 3, and 4.5. And I choose a device 1.15 greater, larger than the greatest diameter. If this number is not the exact, so in many cases not the exact, so I choose the largest available device. When the rims are deficient or floppy, I may choose a size 1 larger. And for my shelf, I order the main size that I elected, plus 1 larger and 1 smaller, and sometimes 2 larger and 2 smaller devices. This is the idea. When you have not a 3D echo, you can do in 4 angles echocardiography at subcostal view, and you can have an image, somehow 3D image you can think and imagine as a substitute to 3D echo. This is the probe at 12 o'clock, and this is the probe at 4.5. For 1.5, sometimes it's not a very good quality, and in these cases, I choose the 1 o'clock. And this is the images, and I measure the ASD, the rims, on all of them, and I choose the greatest diameter for the selection of the device size. So in conclusion, although ASD closure under transthoracic echocardiography is more difficult and time-consuming, it can be safely used for guiding ASD device closure. It is advisable not to use transthoracic echocardiography for the closure of complex defects, multiple defects, and those with poor echo images. Thank you very much for your attention.
Very good presentation. Thank you very much for that. This is something that is very practical, and we really appreciate that. So Behzad, do you think we can start our little break and then we can have some discussion?
Yeah, sure, we can go on.
Okay, so we can start with the faculty. Does any one of you want to comment any of the presentations or have any question for the other panelists?
Maybe can I start?
Yeah, great.
Okay, Warkan, when you're going to have the retrograde approach, one of the main concerns that you may have is about the those structures inside the RV. You know, RV is another chamber. It's not like smooth like a LV. So you have many trabeculations, some of the moderator band and some of the others. And also you may have the papillary muscles of the tricuspid, and also you may have some difficulties with septal leaflet of the tricuspid, after many attachments of the tricuspid septal leaflets to the septum. What is your concern about the tricuspid valve especially, and also the other organ or structures in the RV when you are going for the retrograde approach?
Thanks, Behzad. This is very important question. You know, my practical ways of doing retrograde approach is I need echo. I need at least live echo to show me where I am. As you said, there's a lot of things we need to concern, especially septal defect or tricuspid valve. So you never know without echo guidance whether you entrap with the tricuspid valve or not. So that's why for me, transesophageal echo would be you know, my routine practice. If I don't have it, at least while I'll open the disc on the right side, I will at least ask my colleagues to do transthoracic echo to see the TR and the obstruction of the outflow tract, something like that.
Okay, so imaging is so crucial for you for this kind of approach.
Yep. Yes.
Okay, thank you. Absolutely.
Warkan, I have a comment.
Yes,
comment for a retrograde approach of the VSD closure, especially in some patients with significant TR. In our center, each week, we have some patients with severe TR before the VSD closure. In some cases, it seems you have a significant LV to RA shunt, or in some cases, it seems to have a cleft in the septal leaflet of the tricuspid valve before the closure of the VSD. But our policy, exactly a retrograde approach for evaluation of the TR before the release of the device will be very better than to antegrade approach. But our experience in our center showed in some cases, antegrade approach is very easy and very good option for these patients. Before the release of the device, because you have the cable or the long sheet in the tricuspid side, and evaluation of the TR before the release is very problematic and is very hard. But in some cases, after the complete closure of the VSD in the antegrade approach, all of the TR will be removed and easily you can release the device. It's just our experience in the antegrade approach for some cases with the severe TR with premembranous VSD in our center. But I am very agree with you. Retrograde approach is very good option, and evaluation of the TR before the release is very easy for the operator. Thank you for your very nice presentation.
Thanks for sharing. Tin, what's your opinion on the 3R aneurysmal type defect? What kind of approach you're going to use?
In my experience, yeah, if you're worried about tricuspid valve, it's better you use the retrograde approach. If you're worried about the aortic valve, should be the antegrade approach. With the severe TR due to the LV to RA shunting, we should open the right disc and make sure that the TR become less or disappear. And you have many chances to adjust the disc in the right side. And if we do the antegrade, we cannot to adjust it. What can also show the last slide about the hub of the IDO2 in the LVOT. My experience also no problem, but I prefer to use the retrograde approach for VSD with the aneurysm. And you see the hub can go inside the aneurysm, and it's better. And one thing is very important. Bezat mentioned, if the defect close to the aortic valve, it means it's far from the tricuspid valve. If it close to tricuspid valve, it means it's far from the aorta. And we see when you see the aneurysm, it means the defect close to tricuspid valve. And we can use the retrograde approach.
Thank you, sir. Bezat, may I have a question to you? Bezat?
Yes. Yeah.
Yeah. So if let's say if I'm about to start a VSD closure program in my hospital, and I really want to propose 3 devices to use for VSD closure, and in your opinion, what kind of device that should be available in my cath lab, which is about to start?
Yes, very nice question, but somehow a commercial one. You know, in my country, the availability of these devices is not just to the type of these devices. It's very, very, very many factors to have or not to have any device. But if I want the opportunity to have a device for my cath lab for doing PDA closure, VSD closure, and so on, I used to use AD01. This is the most important one, and sometimes I can use it for everything that I want.
And how about the other 2? Or just one is enough?
Okay, yeah. And if you want to do another things, also occlusive duct occluder, because of the shape, is very important for some kind of aneurysmal VSDs. So the second one, surely, for VSD closure with ADO2 as ODO or occlusive duct occluder. And if I have so lucky to have another opportunity to have another one, I want to ADO2. This is another one that I love to have.
Thanks for sharing, sir. Because that's always an issue. Because when we try to start, the administration of the hospital will ask, why you have to stock so many things? Why just have just one, or just one thing can fit all, or something like that? And sometimes it's not easy. So any other comments on this from the speakers? If you want to share.
I have a question.
Yep. Oh, yes, please.
If you have moderate tricuspid regurgitation and close the VSD and the TR remaining the same, moderate TR, do you close the VSD? And if you close, how do you follow the patient and when decided for surgery or other?
Thank you, sir. Please, if other speaker can share with this is very, very important question. So if for some reason when we close the defect, but the TR is still the same, there will be probably at least two possibilities. First one is TR is not really related to the defect. It may be just isolated or other things, which is not really related. So with that is moderate. You know, I may just following up because the device is in already, and I will not try to ask the surgeon to just do it if the patient has no problem. But if it's that the first possibility not related to the VSD, but second one, if it's related to VSD for some reason when they close, the TR getting worse or even remain the same, I will definitely remove the device and then I will talk to the surgeon. So that will be my policy. I'm not sure about the others.
Can I add something as a surgeon?
Yeah, please, sir.
Yes.
Yeah.
Generally, the idea is that with the interventional cardiologist, if something happens to the interventional cardiologist, can happen. It can happen. If something happens from the surgeon, was a mistake. This is a typical approach for we really, in our center, we love interventional. It means hybrid for VSD closure. We use, we really like, doesn't use cardiopulmonary bypass. So I'm very happy because in your discussion, you are talking about mostly of the tips and tricks of this procedure. And I believe that this is the real way how to share experience. Because at the same time, whatever you make a worse experience is something that the people can learn from this. So I think that your point of the way you are thinking about this meeting and the presentation is the right way to improve something that sometimes is not really perfect or something that is the patient can tolerate. Of course, residual VSD, if it's done by surgeon, is every time big. It's done by cardiologist, the patient can wait. But this is the real world, no problem.
Anyway, thank you very much, Sasha. But, I want to add you something. As Tin told us, when you are going for the retrograde approach, evaluation of the aortic valve insufficiency and the procedure about the concerns about the aorta may be very high because this is no way to evaluate the aortic valve when you are going into a retrograde approach. And when you go for the antegrade approach, because of your sheet is inside the tricuspid valve, and from the tricuspid regurgitation, it's very difficult to evaluate the tricuspid in antegrade approach. So we have two concerns about two approaches. In retrograde approach, the main concern is about the aorta, and in antegrade approach, the main concern is because when you are in the procedure, you cannot evaluate how much the tricuspid regurgitation is really. After that, you may take out the sheet and then consider how much the tricuspid valve regurgitation is really. But when you are going in the antegrade approach, you cannot understand about the aortic insufficiency and what happened when you take your sheet or out of the aortic. So these are always you have to do with your experience, I think.
I have one more question. Do you want to say something, Sasha?
No, I think that we were ready for the next speaker. But
okay.
Can I have just one more question, please?
Yes.
Yeah. So again, because there's a question in the chat box, Q&A box about subpulmonary VSD, I know the answer from Tin, what he will say, he will definitely close VSD. But, you know, Besad may say, I'm not sure about yes or no, but I want to know the opinion from Besad and also Supa. So if you have subpulmonary VSD, will you close it? Yes or no, and why?
Well, Warrican, honestly, I have no experience. I've not a lot experience about the subpulmonic VSD, because whenever I've thought about this, somebody inside me said no, not to go through the this kind of VSD. But most of the times when I want to go to for the subpulmonic VSD, approximately because of the defects so close to the valves, it is always a concern for me. And sometimes I know that there are some experiences from Malaysia, from our teams in Malaysia, that they have some pulmonic VSD with pulmonary leak oil closure, and they had some good experiences about that. And I've heard some about the VSD closure from Teen also. I know that Teen has done some of them with the, some devices like ADO2. I know that, but in my experience, I'm always concerned about the valves and the approximately of the valves, and the it is very difficult for me to go inside, and always something inside me tell me not to go through that. This is my opinion. And Supa?
Yes, for me, I will close if the subpulmonary VSD is small. I will go by the TAN catheter. But if the VSD have the severe aortic collapse or severe AR and very big outlet VSD, I may go for the surgical. Yes.
Thank you.
There's sorry, go ahead.
Just one last question for Tin. For subpulmonary VSD, when will you not close it?
Same Supa idea. I don't try to close a very large defect. It means that the through hole more than 7 mm. Second one is the not too severe prolapse of the trapezoid valve, and also not prolapse of the leaflet. It means no AR. And the last one is not the small baby. The body weight must be more than 10 kilograms. I don't try to close very small baby.
Okay, so let's go to our last question. I want to listen to the panel.
I have small comments.
Okay, go ahead.
Warrican, if you have a significant right coronary prolapse inside of the subpulmonic VSD, exactly this patient not suitable for the intervention. And first choice for this patient is the surgical approach. But don't forget, in some cases, it's possible VSD not to be the subpulmonic, VSD to be the very high intramuscular near the pulmonic valve. In my beliefs, if you have no any significant prolapse and VSD to be in the high intramuscular part of the septum, it's better to go for the closure of this defect with the device, not surgery.
I think we should have one section for the doubly committed VSD closer from the morphology, the echo, and the device, and the follow-up also.
Would be a great idea. We can organize that. So one last question, and then we move on to the next speaker. Do you think, guys, that with the interventional cardiology, the indications to close VSD changed? What I mean is that for small VSDs, we not send this patient for surgery. Do you think because we have the interventional cardiology that can act on that, should we close small VSDs on the cath lab or not? The indication is the
May I answer your question? The indication for closing the small VSD is different from countries to country. Maybe the Eastern or US is quite different from the developing countries. We have many cases with the endocarditis and also social issue also. And some patients, some friends ask me, should my son should be close the small VSD? And I told them, if you are a well-educated person, you can take care well your son. You should not don't need to close very small hole. But when I met the patient with living in the rural area and with the primary healthcare system is not well, I try to close because I should deal with small hole and endocarditis. And yeah, it's my answer.
Thank you very much. And may I add something else? Teen told about the social issues. It is very important about the social issues. You know, when parents come to you and they think that the babies have a very even a small problem in their heart, and maybe there's some limitation for these children not to play, not to go there, not to go there, and not to speak with each other. Anyway, this is a very, very bad thing about these children for growing up with this memorial and this emotional sickness that they may have. So sometimes you have not any special conditions, any special considerations, any special concerns about this VC, but the social issues is always very important. I had a patient with a very small VSD. He was a student in the university, and he came to me, and it was a very small and not a case for any surgical or any interventions. Just leave with him with it. It's no problem for you. And 1 year later, he came back to me that I cannot work with this VSD in my heart. And because of this, there's about 1 year that I've not gone to the university anymore. And I cannot imagine that I have a defect in my heart. So I had to go to the cath lab for closing this small VSD because all the life has been changed for this guy. So I think that social problems are sometimes very good concern about this.
Sorry, I share with all of you this paper because we have a very big discussion about this point. And recently, Professor Andrew Reddington comes with this special paper. I remember when I was a real student, I met once in a meeting Professor Castaneda, and there was a big deal about the discussion how to close or do not close smaller ventricular septal defect. And he told to all of us, you decide to not close, but how these people will live when they will grow up? And now probably we have a part of this paper is from this year, is 2020 on European Journal. I suggest to review this, because again, if you compare to control with the healthy people with smaller repaired pediatric VSD, when they grow up, the exercise tolerance, I know that is not similar with the healthy people. So I think that is important country by country, but science can be based also on this type of choice. So whatever we decide, do not close a VSD in restrictive and other things, we have to consider that probably at 30 years, we see here the case mix of the patient is 27 years in both groups. And you can think that the exercise tolerance with the normal people will be different. So as a surgeon, I suggest, we discussed a lot about this point, and at the end we found, we arrived at this final paper that I think is very important for a patient with a restrictive ventricular septal defect. Sorry for this.
Amazing. Thank you for that, Sasha.
Yes. So we can move now. Well, there is a question man. Where is Gorakan? Question man is still there. You want to do another question? Are you okay? So now it's my pleasure to introduce the colleague coming from Ho Chi Minh City, is Vietnam, is the head of interventional cardiology at the Ho Chi Minh City Hospital, and it's a real pleasure for me to have people, thanks to Besad, because we have really a different point of view about the similar topics. Again, I asked Dr. Dong Nguyen Tin to open his microphone and share the screen.
Hello everybody. Thanks for inviting me to share my experience. Thank the Caspian and Congenital Heart Academy to organize the meeting. And my talk today is BDA stenting, the unconventional cases. I have no disclosure. Unconventional cases of the BDA stenting, it means unconventional morphology for BDA stenting. I will mention about the unconventional techniques and unconventional situation in the BDA stenting. First is unconventional morphology for BDA stenting. Turn back to the publication from Mansini, Malaysia. We say if the patient has a pulmonary branch stenosis and it's a contraindication, and maybe we can do something wrong with the LBA and RBA. Here I show you the case with the BDA and bifurcation stenosis. There may be trifurcation stenosis, the LBA, RBA, and also BDA stenosis here. And also is the bifurcation stenosis, not only the ostium, but also in some parts of the LBA and RBA. And here also you can see the LBA is stenosis at ostium and the post-stenotic dilatation of the LBA. And it's a very difficult case for the BDA stenting. In some cases, the LBA becomes more severe stenosis, or sometimes we see the hyperplastic of the LBA and severe the stenosis of the BDA and bifurcation. In some cases, we didn't see clearly, or maybe no LBA connecting with the BDA. It's a very difficult case. And so the question is, can we do the BDA stenting for this kind of case? And let me show you the stent. If you put the stent for the this kind of case, you see we put the stent, the LBA become more severe stenosis, or sometimes the stent, you see the LBA becomes more severe stenosis after stenting. And some cases also the bifurcation becomes stenosis. It's very difficult. And so can we do this kind of case, and how we can do this? And you see this case, I try to put the stents through the LBA or RBA. It's the lesson problem with LBA or RBA. At first, it's okay. And you see the first stent can open the BDA to the RBA. And I put the other stent for totally cover the totally length of the BDA. But the problem, you see the LBA become more severe stenosis. And what we do? We cross again the throat of the stent and use a balloon, and you can see the final result looks better. And so my experience, if you see the stenosis of the LBA and RBA as ostium, just ostium level, you can use the balloon to dilate it. I mean, if the decreased stenosis of the ostium LBA, RBA, just ballooning is enough. But some cases you see when you put the stent, first stent, you see the LBA becomes more severe. But it's also just the ostium stenosis, and we can use a balloon and we can get a good result. But the problem, the question is how big is enough for the balloon. If we use a very big balloon, maybe we can change the first stent and you can create the stenosis from the BDA to the RBA. And also the throat cannot be opened well if you use a small balloon. And how big is enough? In my experience, we can use a balloon, but the size of the balloon cannot be bigger than the size of the stent. If you use a bigger one balloon, is maybe we can chill the stent and we can cause the big problems. And when you see the LBA and RBA stenosis, it's not only the ostium, but sometimes it may be diffuse the stenosis. The first stent you can put in LBA, and you can use a balloon for the RBA open. But you see the RBA is not stenosis, is not ostium, but a little bit diffuse, and you can use a stent to the RBA. You can see the stent to the RBA is looks beautiful for both sides of the BDA. And from my experience, if the diffuse stenosis of LBA and RBA, you can use a stent, but you need the balloon and stent, and balloon first and stent later. In some cases, you see very severe stenosis of the BDA to RBA and LBA also. And you see when we put the stent, almost after the first stent, almost LBA and disappear. And it's not easy for crossing the LBA again. And you see maybe we fail, we lost the LBA. And you see, luckily sometimes we can cross, but it's a worsening stenosis or complete, and so we're very difficult for crossing again. But luckily I can cross again, and I can open the throat, and you can see I put the other stent for LBA. It looks beautiful, but the problem, if we cannot cross the LBA, is a big problem. And what should we do? You see this case, the LBA and RBA stenosis. And so if we put the stent to LBA, RBA, will be the remain will be disappear. And so my experience, I use a balloon to dilate the LBA, RBA first, or LBA anywhere, and make the whole LBA become bigger. And I put the stent to the LBA, and you see the RBA shunt also still here, and I can use the guide wire cross again easily and put the stent, and you can see I can get the best result. And so how to prevent the totally disappear? Maybe we ballooning the BA brains first. Second, morphology of the unconventional situation is tortuous. Maybe one or more constriction, or maybe very tortuous is contraindicated. You see, if the BDA is is a very tortuous with two or more curves on the way of the BDA. You see, it's a very difficult case. And can we do this? And so the question is, can we do the BDA stenting with two or more curves? The problem is the technical issue, how to cross it, how to advance the stent, and how about the length of the stent, and what we do. Well, we just cross it and don't worry about the length of stent. The first stent just open the pulmonary end of the BDA, and you see the remain of the BDA. We can put the second stent. You can see the remain. You can choose the short or long stent is easily. And so for me, the tortuous of the BDA is not a big problem. It will be straight after stenting, and the length, don't worry about the length. Put the short stent at the pulmonary end first, and remain, you can see how long for the second stent is no problem. And just two short stents, okay. And one more thing is the bilateral BDAs. You see one BDA in the LBA and one BDA in the RBA. And what should we do? The problem for not the technical issue, not putting the stent is not a big problem, but how about the size of the stent for the single lung? If we put the bigger stent, it will be overshunt, and for the both pulmonary, both LBA and RBA. And if the small stent is thrombosis and also the not enough. And so my experience, I can put two stents for the bilateral BDA, but the size of stents should not bigger than 4 mm, maybe 3.5 or a little bit less. It depending on the body weight. But don't use the 4 or more 4.5 mm the size of the stent. And second thing is unconventional techniques for the PDA stenting. You see some cases the small baby, the guide wire can we could not advance the guide wire as more distal as possible, and so my technique is I twist the wire and you make sure that the wire fits well inside the pulmonary, the distal part of the pulmonary artery. And you see, I prefer to use a micro catheter for advance the guide wire more distal, and you can see I fixed the guide wire there, and so you see the steep part of the guide wire crossing and a little bit far from the PDA, and it can support the stent easily. But make sure that the guide wire is not broken. You can use micro catheter, push and pull to make sure that no broken over there. And the teaching the wire is for anchoring the guide wire is a very important thing. And sometimes you see the stent easy to embolize to the aorta. And first stent is not strong, long enough to the pulmonary artery, but if you put the second stent, the first stent easy to go the embolize to aorta, and you can use the pigtail to make sure that the first stent become more stable for advanced the second stent. And it's a technique for advanced two stent. The problem, the guiding catheter should go inside the PDA, the stent, the first stent, and so the second stent go easily. And you see, I use technique, open the balloon, and when I deflate the balloon, I advance the guiding catheter, and you see the guiding catheter go inside. Here you can see very beautiful. It's a very angulation between the PDA and it's a very curved. And when I inflate the balloon and deflate balloon, I advance the sheath. You can see the guiding catheter or the sheath can go inside the first stent, and the second stent go easily for connect the two stents. And here also the first stent is not enough, and so I use the same technique to prevent the stent go embolize to the aorta, descending aorta. You see the guiding catheter can go easily crossing the stent. And the unconventional techniques also, you see some cases, PDA is very small in the pulmonary end, but the ampulla is very large. If we put the stent, it's not too big because it's too big, it's overshunt. It's too small, it's embolized or thrombosis. You see some space between the stent and the ampulla. And so you see some space, there is a high risk for thrombosis here. And so what we do, you see the first stent I put inside the pulmonary end, not just enough for the body weight. But the second stent, I use a bigger stent for the ampulla. And you see I can reduce the space between the stent and the ampulla. And you see the bigger one in the ampulla and smaller one in the PDA. And this one you can see here, some cases the PDA is very sensitive with the BGE1. I use BGE1, the PDA become very large, but when stopped, and the patients will be cyanotic very soon. And you see, if we use a very low dose of BGE1, also PDA very large. And you see what we do. I put the first stent, and you see the first stent is a very big, but not suitable for the small baby. And the second stent I put in the pulmonary end. Maybe the first stent maybe 4.5 for fixing the stent well. But the second stent in the pulmonary artery, maybe I use the smaller one, and I want to reduce the lumen of the first stent. And so it's easy to reduce the lumen without the risk of the embolization of the stent. And the last one is an unconventional scenario of the PDA stenting. First one, you see the PDA looks very beautiful, but when we cross the guide wire, you see the PDA spartum. And this when spartum patient becomes more severe with a hemodynamic compromise and see a severe cyanotic. And at that time, we cannot measure how about the size, the length of the PDA. And the question is which should we stop PDA before the stenting or not? Some center they try to stop PDG1 at least 4 or 6 hours, but some center they worried about the PDA sputum. And my experience, if the PDA is taught to us, I don't try to close to stop PDA BG1 early. I may keep the BG1 maybe just 1 or 2 hours before the procedure. Or this one, should we balloon or direct stenting? If we use balloon, maybe more sputum or some problem. But we use a direct stent. We don't know where is the opening exists in the bone marrow artery, and the first stent maybe not over the bone marrow end. And here is a case, a very interesting case. BDA looks okay, but I could not cross, and I use a micro catheter. You see the BDA sputum, and I tried to cross it, and you see the BDA rejection. It's a very difficult case. When the BDA rejection, should we cross again or we stop? But you see when the BDA rejection is the patient become more severe. And should we use a BGA1 for opening the BDA with the rejection BDA? It's a very difficult case. Luckily, in this case, I can cross and I can use stent to rescue the patient, but it's very difficult. The unconventional scenario of BDA is a stent migration. Stent migration maybe to the bone marrow artery. You can see when it moves to bone marrow artery, it trails to the RBI or LBI again. And we need to put a second stent to cover totally. But also the same scenario with the LBI stent, we should use a balloon for dilatation. Some cases, the stent migration to aorta is more difficult. And the question is, should we remove the stent or should we use balloon, bring the stent back to the PDA? It's not really, maybe we have a section to discuss about that. It's not easy for answer. And the guide wire broken, also the big problem for guide wire broken. You see when I put the stent, you see the guide wires, when I cross the truth of the first stent, the guide wire easy to be broken. And I put the second guide wire for crossing the snare, but the second guide wire also broken. And I put the third one also broken. And so my experience, for preventing the broken of the guide wire, we should use a micro catheter crossing the guide wire. You see the outside the guide wire is a micro catheter, and you can remove the guide wire without the broken. And so it's very important thing for preventing the broken guide wire. My conclusion is the BDA stenting is very difficult procedure, and the patient is very severe and small baby, but very interesting procedure. The results very acceptable for alternative method for the prediction. Thank you very much.
Thank you, Tin. It was a really amazing, very practical approach to difficult situations. Amazing talk. Maybe the last ones we can make a session of our nightmare cases and we can present them again because they are really nightmares and you were able to solve that. So now moving on, we are going to introduce a special guest, and we are very proud to have him, Dr. Frank Ng. He is a professor of pediatrics in the University of California, and he's going to talk to us about venous rehabilitation and recanalization. Thank you very much for being with us. You are still muted.
Sorry. Thanks for the introduction, Grace. So I want to make sure I should just share my screen right now, or what's the best way to do it?
Yes.
Okay. Okay, let me go ahead and do that. Oops. Can you see the screen?
Yes, perfectly.
Okay, perfect. Well, again, I want to just thank you, Grace and actually Gil Warnowski for inviting me to give this talk. This is actually, I was thinking about the topic of unconventional rehabilitation of veins, and actually I'm thinking there is no such thing as conventional rehabilitation. So all of this stuff is unconventional. But what I really want to point out, and this is actually a lesson for not only the pediatric interventionists, but actually the intensivists who take care of sick kids in the ICUs. So the title of this is Venous Rehabilitation and Changing the Paradigm in the Management of Occluded Veins. In other words, we have a certain way of managing veins that are occluded, and I'm trying to get people to rethink about how to do that. So I just gotta figure out how to move my slides. Oh, you go. So this is the current paradigm that we all employ. I call this kicking the can down the road. The problem is that all of us as medical providers at some point encounter vascular access problems, whether they be something simple like a blown IV or infiltrated IV, or we have trouble getting IV access, or the central line is thrombosed. So that's a very common experience among all of us. The solution is that either we put it in or we call a special team. In the US, it's the PIC team to come and do that. They're the nurses that are trained for this. And then once they get it in, the problem is solved, then we go back to taking care of the patients. We don't think about the vein that was occluded, that was the problem in the first place, because we found another vein. The problem is that what happens when the specialist, the PIC team says, I cannot find you access? What do we do next? Well, the next thing we do is we call surgery and say, give me some central access by cut downs, and they do that for us. The problem is what happens when all of the veins are gone. Now what do you do? So this is the paradigm that we face as pediatric interventionists. If we find that a femoral vein is gone, and some of those patients that have had long line for a while, especially when they're young or have multiple caths or surgery, some of those veins are gone. What do? We go to the other side. If both sides are gone, what do? We go to the internal jugulars. What happens when both jugulars are gone? We can go transhepatic, and we've gotten very creative in that. What happens when all the veins are too small and you have to deliver a large system, or you need dual access for very complex interventions? So at some point, patients run out of venous access, or they develop signs and symptoms of venous insufficiency. So out of necessity, we've learned how to recannulate these vessels, but I actually think that we should do them earlier before they extend, get longer, or become fibrotic or symptomatic. So who are the patients that develop obstructive veins? They could be actually asymptomatic, and they just happen to need central access for chronic lines, but they run out of venous access. And most of these are patients with chronic diseases, not necessarily cardiac patients, but certainly some of them. But we see them in congenital heart disease patients. We see them in premature infants who need long and chronic lines. We definitely need see patients who needs TPN because they have short gut syndrome. Now, these are the kids who have NEC and had most of their bowels removed. They need TPN until the guts grow more. Sometimes they need it for life. We have hydrocephalus patients who require ventricular atrial shunts to get rid of the CSF. Now, usually you put VP shunts into the peritoneum, but sometimes the peritoneum gets so many infections they can't put it in. They need the vascular access for that. Cystic fibrosis patients, hem-onc patients, the really sick patients with multi-system issues. And then you also have the symptomatic patients, those patients with SCVC or IVC syndrome. And then you have the thrombophilic patients, those patients with that protein S, protein C deficiency, factor V Leiden, all the various kinds of blood clotting diseases that we see in pediatrics. Again, not cardiac, but you may actually play a role and help these patients. The problem is, it's not a problem until it becomes a problem, and then it's a big problem. I sort of look at this picture and say, this is probably what this photographer was thinking right before he took the picture. It's not a problem until it becomes a problem, and then it's a big problem. So here's an example of a femoral vein obstruction. These are all cases that I've done, and we've actually recannulated them. It could also be up in the iliac veins. It could be up in the distal IVC involving the bifurcation of the iliacs. It could be combinations of both the iliac and the mid IVC. It could also be in the proximal IVC. You can imagine those kids can get quite sick. It can also be above the diaphragm. Here's a SVC mustard baffle obstruction. There's a Glenn baffle obstruction. You see the venous collaterals. There's an innominate vein obstruction. And it gets worse. The subclavians can go. The internal jugulars can go. So you can imagine these can happen in cardiac patients as well as other very sick kids with chronic lines. Here's a thrombophilic patient where the entire IVC is gone. This is a patient with Paget-Schroeder syndrome, where the subclavian vein is compressed by the first rib and then it's the clavicles. This is a good example of a factor V Leiden patient where you can see there is really no true IVC. Everything is making its way up to the heart via collaterals. And this is actually a sentinel case for me. I'm going to show you 4 cases about why these procedures are important. So this is a 5-year-old ex-premature baby, history of necrotizing enterocolitis, developed short gut syndrome after surgery, and is TPN dependent. She's had multiple line infections, and they have less vascular access. She has 1 remaining PICC line in the left internal jugular vein, and that got infected. Now, I wasn't involved with this patient at first, but the team basically tried to treat her infection with antibiotics, leaving the line in. After 2 weeks of antibiotics, she was still bacteremic. So somebody called me to take a look. So this is the first thing I did. I just went and looked and saw what I see. So you can see that this femoral vein is occluded. Now, granted, I'm sure this was gone a long time ago. So you have a very long segment of stenosis and then basically occlusion. You can see how I'm able to run a wire up there. You can sort of see some staining along the pathway of the vessels. And then you can see the left side was like that same thing. So you can see that you can actually, rather than giving up, you can put a very hydrophilic wire, and as some of the techniques that people have shown, you can actually recannularize it with amounts of twisting. As long as you can form a little curve, it actually can push through the soft clot. Now, if it's a long clot and it's old and it's thrombotic, you won't be able to do this. That's why I think it's important to do this earlier than later. So now you find this long occluded vessel that basically is not useful at this point. But there's free flow, usually above the renal veins where there's a lot of inflow. So that's what we're going to have to go after. So because this patient is still infected, we were just going to balloon it and buy some time, put a new central line in. Here's the new central line so that she can get TPN while we remove the old central line to get the infection cleared up. So I told them that when the infection is clear, call me back. So there's the patent IVC, and the central line is there now. Now she can get TPN. So we put a new PICC line in here just for TPN at this time. We removed the old IJ PICC line. And so 3 weeks later, after the infection was clear, they said, can you do something now? So we take him back to the cath lab. You can see that the innominate vein is totally gone here, right? This patient is living off its collaterals. Even if the cardiac surgeons or the general surgeons put cut downs in, they won't be able to run a line through this. But this kid needs a line. So basically we come from below. Now remember, we still have that access from below, and we can see the 2 areas. You can go from above and below. You see that there's an area of obstruction plus a very tiny remnant innominate vein. And this is just a result of chronic lines. So you can sort of see where the vessels are. There's also a stenosis right at the entrance of the right internal jugular vein. So here we have a target, and we're able to find our pathway, get through the tiny little residual stenosis and get down to where you need. You can snare that, and then you can now run a small catheter up there. Just to see, it takes a little bit of pushing but now that you have access on both sides, you can actually pass through that little obstruction, and eventually it'll pop through. You'll see it soon right there. And so we balloon it. And so therefore, it actually looks pretty good. Actually, take that back. It doesn't look very good, but there's access now. This is a lot of times there's recoil. So finally, at this point in time, we put the central line in, knowing that I can't stent it now, but it's better for her to have a central line from the neck than from the groin. So this is just to snare that catheter. This is the central line, just to put it back into position. So now she has a central line. Now, once we've done that, we go back down to the legs, and we basically stented the entire course. Now, we've reestablished that. Now, that is actually planned as a plan B. In other words, if the neckline is infected, we can still have access to this and get rid of the other one. Now, I don't have the other images, but we actually brought the kid back, and we actually opened up the right IJ also. So therefore, now she's got reestablished 3 major vessels for her central lines. Now, remember, this is a kid who is on TPN for life. And so they're going to need vessels to keep the veins so that you can do TPN. And I found this very interesting. Now, this is a paper that came out entitled Indications for Pediatric Intestinal Transplants. And one of the things that came up that was surprising to me was that life-threatening complications warranted consideration for intestinal transplant, including TPN-associated liver disease, recurrent sepsis, and threatened loss of central venous access. To me, that was astounding. What that means is that you're going to send a patient for intestinal transplant because you did not have a vein for central line access. So that's why I think that's really important to make sure we save some of these veins, especially in those kids you know is going to need lifetime access. And this goes beyond cardiology. This is why I think the critical care team needs to be aware of this procedure. Okay, I'm going to keep going. Here's the second case, 19-year-old kid with factor V Leiden. He's a baseball player. And as he was going through his growth spurt, he noticed that his right leg got bigger than his left leg. And he thought that was normal because he was right-handed. That was pretty funny. And he was a baseball player, but he also noted when he was practicing and running the bases, his right leg was swelling more and more. He was very uncomfortable. So you can see that certainly this is not a normal leg on the right side. So because of his history, the workup was found that he had this clotting factor problem. This entire IVC and the iliacs were gone actually. So we basically see that the left side is actually, the IVC is gone, but the left side collateral system was a little more robust. So we're making our way up there. You can see the entire IVC is gone, right? The vessel is just basically tiny amounts of contrast going up the IVC. We get our way up there and we balloon it all up. And you can see this sort of long remaining entrance into the IVC. Actually, it wasn't even the IVC. The IVC was totally gone. He was living off the azygos continuation, and that got clotted. And so you can see that we are put stents in. This is the entire azygos here, and then now we're putting the bifurcation into the iliacs at this point. And you can see that we can actually do bifurcation stents, just like what the adult vascular surgeons do for aortic aneurysms. And this is what we got after 12 stents and a lot of time. So you can see that 3 months later, we brought him back just to make sure there's no residual stenosis or obstructions. We fixed that. It looks pretty good. We post-dilated a little more. And a year later, comes back again just for more follow-up. And you can see how there's actually an obstruction right on that spot there, which we missed before. So we've added more stents in. And so this is what it looks like a year later. We revascularized the entire lower extremity venous system. So you can see there's a picture of the pre, and this was the picture taken the next day. Now you can see the right leg is still bigger, but better than what it was pre. And this is what it looks like 2 years later. He actually went on to play baseball at the University of Hawaii on the varsity team. So certainly he was able to recover his function on the right leg after this procedure and was able to do more sports over time. Third case. Now, this is a 19-year-old with a mediastinal lymphoma, had surgery, had radiation, and developed SVC syndrome. We put a peripheral line in the right arm. You can see how there's just no flow from the right arm to the central venous system. Same thing with the left side. So basically, you know that there's an obstruction somewhere in the central veins above, up in the SVC. So we come from below. You can see that basically this vein, just the IVC goes, the SVC goes nowhere as far as going up the neck or the arms. Same thing with the innominate vein. So we actually put a line in from above, and you can see that the IJ goes to via a lot of venous collaterals as well. And we're able to put the stent through that, and we're able to restore flow from the IJ right side as well as the subclavian. Now, this is really interesting. We took this picture before we started, and here are some subtle signs of SVC syndrome. You notice that the neck tends to be swollen. You see the venous engorgement on the chest. Sorry, my mouth is dry. Afterwards, this is exactly after we did the procedure. You notice that the neck muscles, the sternocleidomastoids, a little bit more defined, and you don't see the veins anymore. This is not photoshopped out. This is really him, the same camera, same pictures. He actually told me that he was not able to sleep flat for 2 years now. He would feel headaches and his head would feel swollen. In fact, he only wore shoes that are Velcro or loafers. He could not tie his shoelaces because he couldn't bend down. So when he came back to see me afterwards, he was showing me that he can lay down flat, he can bend down, and he can tie his shoelaces. So basically, that really was a big improvement from a clinical point of view. We brought him back in, and at that time, we only took care of the SVC as an urgent thing, but we brought him back, and you see that there's a long segment of an innominate that's occluded. Again, if you use access from below as well as from the IJ. You can then find targets with each other, run a wire through, balloon it all up, and basically open up and normalize this. Now, this is all iatrogenic from his lymphoma treatment. Last case, 2-year-old. This is a 2-month-old with a transposition, had arterial switch, had excellent cardiac surgery, but he developed anasarca, basically. So CT scan, this was done at another hospital. You see, there's no flow from the SVC here. So we brought the kid back in. You see how edematous the patient looks, right? Here's a peripheral line showing that there's no flow from the subclavian. The SVC is gone. The IJ from the needle also shows that there's no flow from the IJ. And we come from below, and we can see that. Now, this patient did have upper extremity lines. So just to tell you that these lines before surgery and after surgery are not benign things. Yes, you can get away with it, but you can have patients like this. So here's a patient come above. You can sort of see the obstruction at the SVC level. We push it up a little. You see this sort of rat's nest of venous collaterals. Now, this is a line from above. You can see that there's an IJ. So we shot from below and shot from above just to get a feel for what the distance is. Clearly, this is not going to reopen on its own, right? Because this far apart. And in fact, at this point, I have no idea where the true pathway is. I'm going to keep going. So you can almost see that once you push up, you might find this little entrance here. This is the remnant IJ. Now you're starting to use your wires, and as you push up a little bit, you advance the catheter, and luckily this was still quite fresh. Remember, she was 2 months old, so this was not something that had been long standing. Had this been around for another few months, this would have become fibrotic and we would not have been able to do this. But luckily that kid was transferred to a hospital. We got past through that obstruction. Now you come up to the IJ and you see that basically very tiny vessels. This is still not the place to stent because I have no idea what the blood from the head is coming down to. So we finally make our way all the way up here. Now this is the base of the skull. Here's the clavicles here. So it's really high up in the neck. Now I notice there's some more free flow of the vessel. This is actually the jugular veins coming down from the base of the neck. Here's the jaw here. So you know that this is pretty high up in the neck. We ballooned the whole thing, and at least we're able to open up some stuff. See, there's a clot here. We're actually able to suck that out. In fact, you see more clot sitting right there, and we can pull out some of this in the process. This is just old, long-standing clots after the vein had become obstructed. We also then went after the innominate, and the same thing. You can run your recannulate that, run your wires up, balloon the heck out of it, and then reestablish flow in the innominate vein. The problem is that the SVC was still quite tight. You can see there's some residual obstruction in the SVC area. So we stented that. So now we actually at least was able to reestablish flow from the SVC to the heart, given access to the right IJ, right subclavian, the innominate vein. You notice that the collaterals that we saw before, we don't see it anymore because blood would rather go through the normal vessel when it's big enough. Now, we actually showed this. I actually took my finger, pushed the, you see how edematous? You see the pitting edema. This is before we did the procedure. This is 1 day after. You notice that the pitting edema is still there, but not as bad. 3 days later, notice the face is no longer edematous. There's no more pitting edema. So again, this is really, these are important procedures to save lives of kids, even if the cardiac surgery was fine. This is what the baby looked like. This is what the baby looked like 3 days later. So we actually brought the kid back 3 months later. We know that at the time we just ballooned the innominate vein. We added stents there and basically reestablished flow. 10 months later, further rehabilitation. And we are basically trying to improve the size of these vessels and making sure. Now you notice that there's really good flow through those major vessels to the SVC, and there's no more of the venous collaterals. And then 3 years later, more follow-up, the baby grows. We can now go after this with larger balloons. And then this is what it looks like afterwards. You notice that this stent here is quite small. I mean, we actually had to use a small stent just to get her out of trouble. So at some point, we're going to have to either fracture this or crack it in some way. What she looked like 9 months later, a year later, 2 years later, 3 years later, totally normal. Remember what she looked like when she was a baby with that edema. Had we waited too long, I think it might have been not possible. Again, some people might ask, well, how long can these stents last? This is a hypoplast who had a pre-Glenn evaluation. As a junior faculty, this is what we found. Put 7 stents in. 12 years later, now this kid is a teenager now, or a young teenager, still open. We further dilated. 17 years later. This is now a young adult and basically still open. So these vessels, as long as the good inflow, can remain patent and can buy you some access if you need. So here's one more, and I'm going to stop. I'm sorry I'm taking longer. This is just so exciting to me. This is the most complicated kid I've ever treated. Mitochondrial disease with dysautonomia, multiple endocrinopathies, diabetes, intestinal dysmotility, TPN dependent, recurrent kidney stones, bilateral nephrostomy tube, von Willebrand disease, immunodeficiency disorder, chronic pain, hypertension, asthma, dermatitis, SVC syndrome. Has 3 central lines for all the meds that are not compatible. I've never seen a kid who needs 3 central lines. When we brought him to the cath lab, this is all the drips that he goes home with. This is crazy. So he sits there, and I noticed that when he sits up, this is what it looks like when he lays down. His eyes get really red. He gets a headache. We know there's SVC syndrome. So here's the 3 lines. There's 1 line, 2 lines, 3 lines. And then notice that there's obstruction right here where the lines are. See the radiolucency here. And of course, what are we going to do? We have 3 lines that need continuous medicines. I can't just pull them out, but I have to take care of this. And if I stent this, the lines are going to get trapped. So we had to get very creative. So basically, here's the SVC, 22 millimeters mercury, 12 millimeter in the right atrium. So huge venous gradient. So first thing we did was to put a IJ sheath in, and basically we took a snare and just pull those lines out of the IVC first, temporarily. The meds are still going in, but now it's no longer in the area of obstruction. Now you can sort of see with the lines out of the way, this sort of old, I'll call that biofilm, sort of adhesions from the line that is causing the obstruction. So now at this point, we put the stent in. That was actually not that hard. But now you see the azygous flow, but definitely more flow through this. The thrombi, the fibrotic matter that was there is now being pushed against the side. And now we can actually, the catheter is still snaring this. We took a tip deflector, and now we can pull the catheters back through here. So now you actually have your lines back through the stent so that you're not trapping the stent. The catheters can still be exchanged out, but it's now inside the catheter. And this is what it looks like. Now you remember that area where there was obstruction. Now suddenly looks better. Now this is the flow gradient afterwards. There's no gradient there. And this is the abdominal vessel wall vessels that we saw before we started the cath. This is immediately after. Now there's still some, but certainly no longer looking like this. So let me just summarize this. Change the paradigm. Occluded systemic veins can occur outside of congenital heart disease. Occluded systemic veins, even chronic, can be recanalized and stented safely and effectively. Stented veins can be life-saving for those who are central line dependent, especially those with short gut syndrome. The signs and symptoms of venous insufficiency can be relieved. And the paradigm shift is don't ignore and don't give up on occluded systemic veins. Thank you for your attention.
Dear Professor Inch, thank you very much. I'm Sasha, and thanks again for the opportunity to learn. I'm sure that mostly of interventional cardiology are scratching their hands for what they learn from your experience. And again, it's very impressive because, as you say, most of these patients outside congenital heart disease, inside congenital heart patients, they need mostly of the time to recanalize, to have venous access for chronic therapy, or mostly sometimes in the ICU for simple nutrition or other things. I think that your experience is probably Gil suggests the best because of this, and is unique and is very learning for all the staff. So thanks again. I'm sure we will involve you in future more than nightmare case, because this is what you present. And congratulations again, because it was amazing hear from you and look to your case. Now we are, thank you again, Professor. So we move now to Iran again, to Shiraz, and we have Dr. Hamid Muzegar. Again, is a pediatric cardiology interventionist and chief of pediatric cardiology department in Shiraz University, and he will talk, and thanks again because was the first that connected 2 hours ago, and again he will talk about transcatheter closure of coronary artery fistula with PFM coil. Thank you, Hamid, and please open your microphone.
Thank you, and thank you for organizing committee, Grace, Behzad, and other heart committee member. I want to talk about the transcatheter closure of the coronary fistula with PFM coil and share our experience in our center. No disclosure. Successful occlusion of the coronary fistula have been reported with various types of detachable occluding device like detachable cord and balloon, unplugged vascular plug, occluder type 1 and type 2 VSD devices, and MFO devices. The aim of this study was a review of our experience in transcatheter closure of the coronary artery fistula with PFM coil and midterm clinical and imaging follow-up. In our study, we reviewed our database 209 to 219. Echocardiography was done for all patients before and after the procedure, 3 and 6 months later, and yearly follow-up. And computer tomography or angiography was done for them at least 1 year after the procedure. Totally 12 patients with coronary artery fistula underwent transcatheter closure. The mean age of the patient was 2 years old and mean weight was 8 kilograms. The most common cause of evaluation of the patient before the catheterization was excessive perspiration and heart murmur. Origin of the fistula was from left in 66% and 33% was from the right coronary artery. Drainage site was in 8 patients was right ventricle, in 2 patients to the right atrium, and 2 patients to the coronary sinus. This is the demographic data of the patient. I selected the interesting cases to show you. The first case was a 28 days old neonate with respiratory distress, continuous murmur in right upper sternal border, RV tab, and loud P2. The LV injection showed aneurysmal dilatation of the proximal part of the RCA. This is the aortogram that showed the aneurysmal dilatation of the RCA and fistula to the SVC to RA junction. The wire passed from the fistula tract to the RA and the coil inserted to the fistula, and the coil released. As you see, there is no residual flow after the closure of the fistula. In a 5 years follow-up, the patient had normal function, no EKG changes, and no embolic event. The patient was, due to aneurysmal RCA, was on aspirin for a long time during these 5 years. Case was 4-month-old boy with excessive perspiration and tachycardia, with continuous murmur in lower sternal border, increased cardiothoracic ratio, and normal heart function. In echo, showed the large dilated fistula tract near the left coronary artery. This is the aortogram that shows large fistula tract that drain into the coronary sinus. This is the RAO view that shows the opacification of the coronary sinus, and this is the caudal view, the same. The wire passed from the coronary sinus to the RA and snared, and the coil inserted in the distal part of the fistula. After the closure, you can see the left coronary well, and this is the final result of the closure of the fistula with minimal residual that gradually stopped the loss, and it's closed after 2 weeks, and the patient had no problem after 3 years. This is the CT angio of this patient. After 1 year that you can't see any fistula tract, no more. Case 3 was 2 years old girl with excessive perspiration, with continuous murmur, increased cardiothoracic ratio, and normal heart function. This is the fistula that drained into the RV. The wire passed from the fistula tract to the RV and snared, and this is the coil that inserted antegradely, and this is the final result that complete closure of the fistula is seen. In follow-up, after 6 years, the patient had no problem and is under follow-up without any residual defect and no fistula tract in the evaluation. And case number 4, the patient with tachycardia. The fistula tract is long and tortuous to the apex of the right ventricle. The wire passed from the fistula tract to the pulmonary artery, and the catheter inserted to the fistula tract, and in the mid part of the fistula closed with the coil. And this is the final result without residual defect seen. In 2 years follow-up, the patient had no any problems. Case number 5 was 2.2 years old with perspiration. This is the tortuous fistula that drained into the right atrium. The wire could not pass from the tortuous fistula tract. Due to this, we decided to close it retrogradely by the coil. In follow-up, this patient, after 1 year, angiographic show no residual fistula tract. Usually, this fistula tract closed with clot completely, and there is no fistula tract after 1 year. This is the caudal view and aerial view that show the normal coronaries and no fistula tract after 1 year. Case number 5, 5 days old with a sign of heart failure. The echography showed moderate TR, moderate MR. The fistula tract passing behind the mitral valve and draining to the right ventricle. The course of the fistula tract was like circumflex coronary artery. This is the angiograph of the neonate. That's the fistula tract passing around the mitral valve. This is the caudal view, and this is the passing of the catheter to the RV. The fistula tract closed retrogradely, and this is the final result of the device closure. In follow-up of this patient, this is the echocardiography that this is the coil, and there is moderate mitral regurgitation and some LV dysfunction. This is the coil near the posterior mitral leaflet. This is the short axis view. This is the coil in the posterior wall of the left ventricle, and this is the long axis view that show the coil near the posterior mitral leaflet. In follow-up, this patient had moderate mitral regurgitation and some LV dysfunction. That's mitral regurgitation gradually increased. Due to this, after 8 months, we decided to send the patient for mitral repair. In the mitral repair, the patient had some type of arcade posterior mitral valve and small residual fistula tract yet. The surgeon closed the fistula tract and also repaired the mitral valve with ring, and also repair of the mitral valve. That the patient is followed is well. In case number 6, in 1.5 years old with his history of the excessive sweating during feeding with continuous murmur and LV enlargement. The fistula tract was originated from near the right coronary sinus and draining to the RVOT. This is the fistula that's opacify pulmonary artery. The first coil was inserted to the fistula, but the patient had significant residual. Due to this, another coil inserted retrogradely. The patient, after 1 year's follow-up, had still some residual, but the patient was asymptomatic. Due to this, another catheterization was done, and residual defect was closed with another coil. After closure, the patient developed, after the closure, After the closure, the patient had chest pain the night after the closure, but no EKG changes and some rises of troponin. During the problem is solved, and during the follow-up, the patient PET scan was done. The scan was done that shows some ischemia in the lateral wall of the LV and apex, but normal heart function and normal LV volume. The patient had in aspical echocardiography also showed some decreased strain in apical parts. After 3 years follow-up, the patient had normal heart function, no chest pain, normal exercise test, and aspical tracking also improved. This is the summary of our patient. In conclusion, transcatheter closure of the coronary fistula with PFM coil is feasible and effective with low mortality and morbidity. According to a small profile and good closure rate, PFM coil seems a good choice for closure of the fistula in children. Due to the remaining of residual after retrograde closure, anti-cardiac closure is preferable with this device. Thanks from the other colleagues, Dr. Draki, Dr. Borzuri, Dr. Ajemi, and our cardiac surgeon, Dr. Amir Gofran. Thanks you for your attention.
Well, thank you very much, Amit. That was very amazing and very great. I've just a very brief question, taking the time, just a short question. What do you think about the future of these kind of patients, and what do you think about the anticoagulant therapy, warfarin, aspirin, and how long do you do this?
For the first patient that had aneurysmal right coronary artery, we put the patient right like Kawasaki disease on the double anti-plaquette therapy with aspirin and Plavix for long term. For other patients, after 1 year of follow-up, if the patient had no residual fistula tract, we stopped the aspirin, and the patient had no problem after in midterm follow-up.
Okay, so usually you don't use any warfarin for these patients for long term?
No, none of our patients receive warfarin.
Okay, okay, thank you very much. Well, before going to the next speaker, I should say that today is the birthday of Hamida Muzigar, I think, today. And so congratulations, Hamid, for your birthday. And well, next speaker would be Supaporn Roymani, my friend from Thailand. He is an interventionist from Songkala University in Thailand. So I don't know the pronunciation well, but I think that's right. Anyway, thank you very much, Supa, to join us today from this Caspian and Congenital Heart Academy. So would you please start? Your microphone is unmuted. Okay.
Okay. Okay. Can you see my slide?
Yes, perfect.
Okay, yes, okay. Good evening, everyone. Thank you, Bersat and Congenital Heart Academy and Caspian for inviting me to join this meeting. It's my great honor to share my case with all you guys. I have nothing to disclosure, just a little bit introduce my workplace. I'm working in the Prince of Songkla University in the southern part of Thailand. We're covering 14 provinces in the southern part of Thailand. Waragan used to be my boss. And we have 4 staff and 1 fellow in pediatric intervention. I just like to show you a little bit. My workplace is close to the beach, just in case you have to missing the vacation in the COVID era. Okay, and back to our patient. Who can guess from this picture where is the destination of the vascular plaque? Tin Waragan, please help me. Or Besas.
Sorry, what is your problem?
This is the AP view and I use the vascular plaque. Can you guess where is my vascular plaques?
Yes.
A venous connection, I would say that.
Okay.
Or probably AVM.
Okay.
Yes,
sure.
yes, maybe in the pulmonary web.
Okay. Okay. Actually, it is a right main bronchus. Sorry that this is not a congenital heart disease because Bessa tell me that you should have the talk about the unconventional. So my conventional work is about the congenital heart. So a part of the congenital heart, I have to find something else. So this is a case that I was consulted by the adult pulmonologist to help her patient. Patient is a 61 years old male with underlying disease of the metastatic renal cell carcinoma at the right lung, and he underwent the right lung pneumonectomy, which is complicated by the bronchopulmonary fistula from the brachial stem leakage, and this is failed for the surgical flap for twice, and also failed from the sealant. So he's suffering from the recurrent aspiration pneumonia and also have the problem of the hypersecretion. So his doctor want me to help to need to treat something to this patient. This is the photo from the bronchoscopy. This is a multiple orifice of the bronchial stem dehiscent. This is a right main bronchus. The right main bronchus ruminal diameter is about 16, and the tree hole is about 5 to 8 millimeter. Anyone want to? If this you facing with this problem, which device you gonna use, or any comment on this? Tin, you are the expert in everything.
If I were you, I may use the device without the retention disc because I want or the less retention disc. I think it's the best maybe plug 2 or IVP 2 or IVP 1.
Yeah, Super. I'm still not understand completely what I'm gonna dealing with this now. But anyway, I totally agree with Lynn that we need something which is quite measurable. We don't really need something having a big disc and a small waist, but we need something like a tubular one, I think.
Super, I think also I agree with Warwick because you have no tools for a very good measurement. So I think the most important thing is to choose a most bigger disc that you can do. I think I'm not sure how you can measure the orifices, measure the divide, measure the fistula. It's very difficult. You have you have some limitation for injection, I think.
Yes. In this case, at that situation, I am also very uncertain what device I gonna use. At first, he asked me to use like the impulsor septal occluder, but I'm not sure what beneath the orifice of this because it's the empty space of the right lung, and I'm not sure how about the tissue underneath the orifice, whether it's have a fibrotic that we can open up the large disc of the ASD device or not. So at that time, I think I will use the vascular plug to sit in the middle of the lesion. And because of the luminal diameter of the bronchus is around 16, so I think I will use the 16 millimeter to cover all the hole and use the body of the plug to stent the middle of this orifice to keep the device inside the bronchus. So this is my idea. So we did it under the patient was intubated, and we did the patient under the general anesthesia. As you see here, I do the TAN catheter using the implanted vascular plug, and the pulmonologist use the visualized bronchoscopic we do together at the head of the patient. So as first, I put the implanted vascular plug. I will go for this. Yeah. As first, I deliver the 16 millimeter implanted vascular plug in the empty space. At that time, it's very difficult to find where to open the body of the device, and I use the bronchoscopic to guide the orifice of the opening of the leakage stump. And as you see here, the middle is very small, and the body is fit well with the small orifice, and this is covering of the right main bronchus. However, the bronchoscopic shows some leakage from the small hole beside the middle hole. So we put another vascular plug 8 millimeter beside it, as you see here, to complete occlusion of the all hole. Technically, to deploy it is the same when you use the vascular plug with the vessel, is nothing different. Yes. And when we put two device, as you see here, the big one is here and the small one beneath the big one is from the, we can do the bronchogram and it show no residual chance, and also from the direct bronchoscopic view, they also no residual chance. And this is our team to do that together. This is the first time that we try to figure out somehow to help the patient. As you see here, this is a chest X-ray of this patient. The device is here. After the procedure, the pneumothorax is a little bit smaller, but the thing that better that the patient have no pulmonary infection for 20 months. However, he was expired by the brain metastasis. Yes. And I would like to emphasize that implanted vascular plug can also use in the unconventional way to close the other thing apart of the vessel, like this case, the airway lumen. Yes, like us, any device or anyone, I want to emphasize that you can always do, okay, you can always do more than you think you can. Thank you.
Amazing talk, amazing. We are very, very happy with this meeting because all talks are very high quality and very practical approach. Thank you for Caspian for doing that. Azad, I think we have maybe some time for one quick question or two. Sasha, is that okay?
Yes.
Yes. Well, it's very amazing, Supa. Thank you very much. I had never had such an experience with doing that. We had a very few experiences with the stenting of the bronchus, but not for the making a device in the bronchus. It was very amazing. Thank you very much. And it means that you and your team in Thailand, especially Warrican, your boss, are working so hard. Thank you, Warrican, also. Thank you.
Well, Bezad, actually, this is so unconventional kind of thing. And well, you know, I don't know. Unfortunately, that time I wasn't there because previously I was with her, you know, that was about 12 years back. But now she's a boss. I mean, her own boss and her team, as you can see from the photos, that she had very great team here. So congratulations for Supar and her team in the Prince Songkla University Hospital as well. Yeah, so that's fascinating. I haven't thought about that. The vascular plaque can close and it can block the air flows as well. Now I can learn that not just the blood but also the flow from the air.
Okay,
actually, I have one more case also about this problem.
Wow.
Oh, great. Oops.
Yeah.
Very nice. Very nice. And at the end, once again, I want to thank you all, the Caspian faculty, and also a great support from Congenital Heart Academy, from Sasha and Grace. Thank you very much for giving to the Caspian faculty this opportunity to join with you. And I hope we can also have more meetings in the future. There are lots of other guys from the Caspian team, and I know it was very amazing for me. This kind of we had these days, thanks COVID, this is the only positive thing that COVID has brought to us, and I hope we get rid of this very disaster of the world, because I know in my country the situation is not so good, and I know that Hojat is also infected, and I hope that he's feeling better today. And anyway, I hope we get rid of this disaster and we can see everybody face to face very soon. And anyway, I should thank Sasha and Susan and Grace for this opportunity. Thank you very much.
Just want to say, everybody, please join us tomorrow with Dr. Anderson, who is going to talk about isomerism. This is going to be nice. Boss, do you want to say something to close it?
Yes, I want to say that again, when there is one crazy guy, that he needs a lot of crazy guy that comes to him. So, Bezad, thanks again. We are very happy because, as you said, for us, COVID was an opportunity. And we want to continue to use this very bad moment to share experience and science with colleagues from all over the world. So today we have 235 people. And as you say, there is people from Mexico, from Australia, from Austria, Russia. So it's a unique opportunity because it's impossible to think at the moment a Congress in presence that will make this happen. So thanks again. We love to collaborate with Caspian, and I'm sure we will do soon another opportunity together. Compliments to Romaine, because the case you showed was very amazing, really unconventional.
Thank you very much.
Thank you very much.
Thank you.
Bye-bye, guys.
Thank you.
See you tomorrow.
Have a nice day.
Thank you very
Thank
much.
you. Bye.